Hi and welcome to our webinar, Those Not Covered, What Happens When Public Health and Immigration Debates Clash. My name is Roqiya Dehqan and I will be your host today as we explore the links between immigration law, migrants' health and public health in the UK. This webinar is the fourth and the last in a series called Borderings, Migration, Gender and Health. The webinar series started a year ago as a collaboration between our center, Lancet Migration, and Migration Research Unit at the UCL. It was designed to look at the borderings of these key areas. This series aims to address and overcome borderings between people with different backgrounds and experiences. The idea is to encourage cross-disciplinary and cross-sectorial dialogues. I do believe that the Gender Center is just the right place for these kinds of conversations. Gender and feminist discourse are about exposing and challenging borders, disrupting and transgressing them. This is because borders are essential for othering, for creating us and them. They are fundamental to the construction of marginalized individuals and communities. Borders make some lives unlivable. They make some sufferings and death invisible. Or as the feminist philosopher Judith Butler puts it, borders make some lives ungrievable, only because they happen to be on the wrong side of a border. There are different kinds of borders and border crossings. Those who cross the border we find on maps are called international migrants. The UN estimates their number at 272 million. Migration is not a new phenomenon, but in recent times we have come to study and understand it better. One of the many reasons we take interest in migration is because of its implication on public health and migrants' health. And that is what our panelists will be discussing today. Before we get started, I wish to emphasize that while we will be focusing on the UK, similar immigration laws impact migrants' health across other European countries and other high-income countries. So please take what you hear today and find out how the same laws are operating in your particular context. With that said, we are really fortunate to be joined by fantastic speakers today. We have a total of 6 speakers and 4 presentations. I will introduce each speaker before their talks. For now, suffice to say, our panelists are very fitting to the title of this webinar series. They don't fit into one box. They do work across borders. They are doctors, researchers, activists, and more importantly, they are people with lived experiences. So now, without further ado, I am really excited to introduce our first speaker, who will set out the context for today's webinar. Dr. Jess Potter is a consultant in respiratory medicine, public health researcher, and activist. Her research focuses on access to healthcare and the structural conditions that shape these experiences. Over to you, Jess. Thank you. Thank you.
Thank you, Roqiya. Let me just share my screen. Thank you very much for inviting me to take part today. I'm going to talk about public health, immigration, the law, as Roqiya has said, and draw on my research exploring migrants' experiences of pre-entry screening for TB in India and healthcare access in the UK to illustrate my points. So, to begin with, what is public health? At its core, public health is has the aim to promote, protect, and enable the health and well-being of populations rather than individuals, and through the organised efforts of society to do that. Within this definition, I quite like the UK Public Health Association explanation, which includes a focus on the root causes of illness and disease, i.e. the social, biological, political, environmental determinants of health, And central to many definitions is also the importance of addressing inequalities and justice. So what is public health law? Frequently, I think that we conceive of public health law in terms of quarantine laws, like the restriction of entry to the country by diseased bodies as exemplified in the Aliens Act 1902, or the notification and isolation of people with infections like scarlet fever, as we can see here in this sign, or the restriction of liberties, as we've seen most recently laid down by the coronavirus lockdown laws. However, I think it's also really important to remember that laws which create public health law also creates the conditions for people to be healthy. Examples include the governance of water and sewage systems in one of the first public health acts in the UK, restrictions on tobacco advertising, enforcing of seatbelt use, and of course, most recently, the sugar tax. Key tensions in public health law frequently exist between the rights of individuals and the state in the state's interest in the health of the public. In the case of immigration, a similar tension can arise when the state positions the rights of individual immigrants as a threat to the welfare of citizens. Lawrence Gostin is one of the professors who's most famously written about public health law and tried to define it. And I think that, going forward across this presentation, please think about these criteria which he's asked people to consider when balancing that tension between individual rights and public health law. So is there scientific evidence that an individual poses a significant risk? Is the intervention the least restrictive possible to achieve the public health goal? Are the measures used likely to gain the public support and confidence? Does the person have access to due process to challenge the intervention? And is the measure arbitrary or discriminatory? And where such tensions exist, we can often find evidence of paradox. Screening immigrants for infectious diseases is not a new phenomenon. Anyone moving to the UK from a country with a high incidence of TB must undergo pre-entry screening for the potentially infectious form of TB, pulmonary TB. A Public Health England employee that I interviewed during my research told me that pre-entry screening for TB was, and I quote, a normal policy used, quote, not for exclusion, but rather to ensure that people are treated properly, end quote. Such framing of policy concerns uses the language of healing, and that directs inquiry towards questions of how policies might govern better or heal more. Applying Foucault's lens of governmentality allows us instead to address questions like who governs what, according to which logics, with what techniques, and towards what ends. Clients I interviewed who had gone through the pre-entry screening for TB described a sense of harm and injustice. One woman had to move her children to a school near the pre-entry screening centre because TB treatment had to be done by directly observed therapy in an officially sanctioned centre. Her visa was linked to her child, so her children couldn't go with her husband ahead of her, and they had to stay in this strange city for 6 months so she should complete treatment. And that was despite the fact that her sputum did not have any TB in it, and therefore she was non-infectious. In addition, I conducted an ethnography, and the corporate glamour of the pre-entry screening clinic stood in stark contrast to the road outside and the city's public hospitals. UK-bound clients wore the latest fashion, carried mobile phones and laptops, while many of the people that I could see on the streets below slept in shacks at the side of the road or walked around in bare feet. There's a stark difference in incidence of TB between these two populations within India. And positioning pre-entry TB screening programs in terms of mutual benefit detracts from the unequal starting position of donor and recipient countries in terms of both relative wealth and also TB burden. Another person that I interviewed pointed out, and I quote, sorry, I want to mention one thing. If you're visiting the UK, for example, if you're on a tourist visa, or if you're just joining family for a short stay, you don't have to undergo that TB test. And I would add, if you migrate from a country with lots of TB inside the EEA, like Romania, currently you're not screened. Contrary to this large poster from the waiting room, clients described how the process placed their lives on hold. And so, through the bias securitization in Warren's language of some but not all offshore bodies, some but not all offshore TB, some but not all infectious diseases, pre-entry screening becomes a selectively permeable border force, reinforcing global inequities and racialized hierarchies and placing UK lives above those of others, as Rogia mentioned in her introduction. Back in the UK context, immigration laws continue to clash with the public health agenda. In a decidedly anti-immigrant environment, a consultation on migrant contribution to healthcare was launched. Policy documents frequently invoke notions of fairness in order to justify restrictions to care for non-citizens. The right to health is enshrined in international law. However, since its inception, the NHS legislation has crept in to restrict access to NHS for some migrants. And this has ramped up in recent years with the 2015 Charging Regulations, which excluded students and people moving here to work from free NHS care and ensuring that they have to pay an immigration health surcharge. Following that, the 2017 regulations introduced upfront charging for non-urgent care which could then be withheld if a person was unable to pay. NHS bodies are now required by law to identify a patient's chargeable status at the first and each subsequent health service encounter. Over the course of the last 15 years, access to the NHS has become increasingly limited, excluding many people, and particularly undocumented migrants and failed asylum seekers. While these laws create mechanisms through which the right to health can be denied directly, other laws, policies, and practices construct an environment which deters migrants and anyone racialized as foreign. Surveillance is an important component of infectious disease control. However, surveillance is also central to policing and immigration control. Confidentiality sits in between and is recognized in law as a cornerstone of medical practice, but its position is not absolute. A memorandum of understanding between the NHS and the Home Office argued that immigration control was a reasonable explanation for routine breaches that placed the security of individuals seeking care at risk, generating fear and acting as a deterrent to healthcare access. Delayed treatment for TB, for example, places individuals and communities' lives at risk, and concerns of data sharing dissuade healthcare workers from recording data which could be used to improve disease surveillance. Returning to NHS charging, like most infectious diseases, TB is exempt. However, healthcare access is a social process with people's experiences shaped by the surrounding environment, including its constituent laws, cultures, policies, processes, and of course, people. The NHS presents a hostile environment to migrants in the form of posters and racialised and discriminatory determinations of deservingness, which creep into the implementation of laws written in seemingly sterile and non-discriminatory language. Contrary to the exclusionary tactics of pre-entry screening, the exemption of TB from charging regulations confers a form of what Didier Fassin and Miriam Tipton have described as biolegitimacy on the bodies of infected migrants. However, as Tipton points out, humanitarianism is about the exception rather than the rule, about generosity rather than entitlement. And so the logic of TB as exception, I would argue, is far from humanitarian and anything but apolitical. Instead, TB's exemption from charging reveals the sorts of lives the hostile environment lets live. Bodies carrying TB are only treated because they are positioned as a threat to national security. My final slide. So in this talk, I think I've shown that public health law is constructed within particular political contexts. It's interpretable with impact dependent on how the law is implemented. Who, for example, knows their rights and is able to ensure they are upheld, affects implementation. And finally, laws are frequently contradictory. Drawing on Agamben's work, we can see how the hostile environment has created a state of exception for migrants, in which through their exclusion, they come to be included in the state's juridical apparatus. The result is the forcible exclusion from political life and the rights this affords, rights such as healthcare. Until nation states relinquish their power to invoke a state of exception, some or other human being will always be produced as Zoe, bare life, undeserving of citizenship and the protections and rights this affords, and rendering them killable under the law. Thank you very much.
Thank you so much, Jess. That was really a very helpful overview. You made it really clear how public health is tightly linked with politics in form of public health laws and social determinants of health. Now, I also appreciate you sharing with us your own research, which I think shows very clearly kind of the complex and nuanced relationship, and sometimes even a paradoxical relationship between public health and migrants' health. And one could see how we end up with ethical and moral dilemmas as a result. And as someone interested in gender discourse, I'm really glad you mentioned body politics. It actually, you also illustrated how politics and power signify bodies of migrants, for example, as a threat to security. You also hinted on the narratives that are that underlie the hostile environment, like the narrative of nationalism, security, citizenship, but also racism. So thank you very much for that. I would like to ask you some questions, but I'd rather do it during the panel discussion at the end. For now, I let our next two speakers to expand on some of the points you made when sharing your own research data. Our two next speakers are Sarah and Jonathan. They will speak about the key findings from a recent study focusing on an area that public health traditionally takes interest in, and that is the health of pregnant women and children. Dr. Salah Botros is a pediatric doctor in London with a special interest in safeguarding migrant health and the health response to modern slavery, human trafficking. She has worked with migrants both in the UK and in Egypt. Dr. Jonathan Borod is a pediatric doctor in London. He's currently working in Rwanda and he's calling from Rwanda. He told us there is a storm in Rwanda, so we hope that he won't get cut off. He's also an academic at the University of Oxford and an activist. So, Sarah and Jonathan, I will hand over to you now. Thank you.
Hi, everyone. Can someone just give me a thumbs up if they can hear me with the storm? Yeah. Hi, everyone. Thanks so much for coming and thank you for the opportunity to speak. So we're going to talk about healthcare access for migrant children and pregnant women. And we're going to draw on some work that we've done with child health workers across the UK. Sarah, can you change? Thanks. So we're going to talk a bit about healthcare access and children's rights. We'll talk a bit about what we did for our research, what our main findings were, and then how this has led on to advocacy and what we're going to do next. So just a bit of context. This number is probably an underestimate, and the most recent estimates are higher than this, but there's at least 144,000 undocumented children in the UK, which means that they lack formal settled migration status. There's lots of routes by which children may become undocumented, such as their parents lacking documentation or their documentation expiring. Perhaps they overstayed a visa. Perhaps they are a refugee, but they've had their asylum claim rejected, at least initially. Often there are unrecognized victims of modern slavery or trafficking. The other context to bear in mind, drawing on what Jess said, is that it's a very class experience migration, and it is exceptionally expensive if anyone has ever had to do it to become a British citizen or to get any sort of settled visa in the UK. So becoming undocumented is a class-based issue and exceptionally expensive. So just as a brief introduction, the charging regulations have been introduced and increased over the last sort of 4 to 7 years, including for children and pregnant women. And that means that they are charged often at 150% of the cost of providing the care, which might be up to £9,000, for example, for just a normal birth for a woman. And these charges are, except for in emergencies, are placed upfront. So you have to pay before you'll get the health care, unless they are emergencies, in which case you still pay, but you pay retrospectively. That's a very brief introduction, and we're happy to take questions about the specifics of the charging regulations later. So I'll go on to talk about methodology. We wanted to understand, since the introduction of a massive expansion of charging in the NHS, how much healthcare workers understood about them, and to try and gain evidence of impacts on patients and on families. So we developed a survey with us, children health doctors, as well as working with a charity and advocacy group called MedAct, as well as working with policy people from our kind of national body for child health, which is called the Royal College of Paediatrics and Child Health. We had just over 200 responses to the survey, and that was from across all the 4 nations in the UK. And I'll just briefly touch on the overall findings. Quantitatively were that most clinicians completely disagreed with charging children and pregnant women for healthcare. And also most people that responded to the survey couldn't understand the extraordinary complexity of the regulations, the exemptions and everything, and found the actual application of them unintelligible. So I'll just draw on the main themes, and then I'll hand over to Sarah. So the main qualitative data themes that we came up with from the responses we got were as follows. First of all, charging had introduced a kind of fear of engagement with healthcare amongst some families who felt that it was actually terrifying to access healthcare, and were subsequently deterred from accessing healthcare, which could lead to a delay or a denial outright of them accessing the care that they needed. This obviously had health outcomes for the children and families represented. There's also a big theme of a hostile environment influencing health. So not just the actual specifics around being charged, but also the wider hostile environment policies and housing and in the wider society. This also had repercussions for NHS in terms of creating an exceptionally burdensome, emotionally painful sort of experience for clinicians that had to implement, kind of deterring people from healthcare and seeing the subsequent harm. And finally, the fact that actually implementing charging within an otherwise universal healthcare system, trying to define a group of people who are by their very nature extraordinarily diverse, was unworkable and very frequently led to errors. And subsequently, people were charged incorrectly even by the regulations. So that's an overview of the themes, and I'll hand over to Sarah to go into in a bit more depth. Thank you.
Thank you, Jonathan. So what we decided to do, as Jonathan said, there was a lot of things covered in the survey in terms of the knowledge of clinicians and their attitudes to the charging regulations, which were both sort of low levels of knowledge in general. But what we decided to cover in the next 3-4 minutes that I've got left is really give you a flavor of the cases that were reported to us, and really just give you quotes of things that came out in the survey to together think through some of the themes that this survey highlighted. And just one thing to clarify before I move on, in terms of charging regulations in the UK, they mostly apply for secondary care and community services, so not for A&E and GP care, for those of you who don't know much about the charging regulations. So we were provided with quite a few cases from maternity care, because obviously anything to do with restricting access to maternity care will have an impact not just on the pregnant women, but also on children. And this is just a flavour of some of the cases reported to us, and I'll highlight the first and the third. Was a pregnant woman with delayed accessing maternity care for fear of charging. And when she finally presented, essentially she was unwell and had the baby who had died in utero, so had died while the baby was still in her. So obviously this is a very dire consequence of fear of access healthcare, and this is a completely preventable problem. So if this woman had been followed up, probably this wouldn't have happened. Third case was a woman who had been trafficked into the UK. Her partner had all her documents. She was also being domestically abused. She was told at her first antenatal appointment that she would have to pay, so she avoided antenatal care, attending instead in labour with a newborn with potentially preventable complications. One of the things in this survey is we made really clear that people shouldn't give us too much detail on the patients that they talked about so that it wasn't identifiable. So we don't know what these preventable complications were, but you can see that despite there being an exemption, so one of the exemptions is for people who are trafficked. In practice, that doesn't work because you don't, as Jess said, with TB, you don't carry a sign walking around saying I'm trafficked. And to be recognized as someone who's being domestically abused or trafficked, you need to have built rapport with the clinician. You need to have really developed a trusting relationship before these things can come out in a conversation. And as you can see, the last case is also someone who was trafficked. So trafficking is a theme that comes up over and over again in charging regulations. In terms of cases that were reported to us from children with denied or delayed care, I'm not going to read all of this, obviously, and this is just to show the sheer volume of cases that were reported to us from just a short survey that lasted about a month and a half. And you can see that most of the conditions where children were denied care were children with cancers, with cardiac conditions, and really with quite complex life-limiting conditions, brain tumors, complex brain pathology. And all of these children had either care significantly delayed because of trying to figure out the regulations or denied. One of the themes, as Jonathan said, was that the regulations were essentially unworkable. So we had, as I said, the cases of women who were trafficked, who were denied care without anyone figuring out that they were actually exempt. We also had a case of a 2-year-old boy who's a refugee on a resettlement scheme, who was turned away by receptionist staff for a hospital appointment of a life-threatening illness. So this is just to show how complex the regulations are and how they're very difficult to understand for vast majority of people. And it's often admin staff who will try and be applying these regulations, and they can make errors. And this is just an example of a child who was turned away from an appointment for something that they really should have attended. And then a lot of cases brought out a lot of ethical and very complex safeguarding implications. So the top case is one that I want to read to you. Was a child brought to A&E by their mother on a bus. When they arrived, the child was seriously unwell and admitted to the pediatric intensive care unit. So that's someone who's very, very unwell and required significant breathing support and other life-saving measures. The day after admission, we had arranged, so this is the clinicians, had arranged a translator to help us explain to parents the condition of their child and our treatment plan. The child was very unwell. So you can imagine this is a very, very stressful moment. During the meeting, the overseas patients team came unexpectedly and used the same translator to explain to the parents that they would need to pay the full cost of treatment. This was the kind of cost that would be in the several tens of thousands. Now, just think about what that does to a family who are trying to grapple with a very, very sick child and suddenly being told about this amount of money. In that case, further on in that report on that case, there was also, they also told us that these parents considered whether they needed to take the child out of pediatric intensive care, which obviously, as clinicians, we wouldn't allow that because it's not in the child's best interest, but these parents were suddenly left with these impossible choices and really complex decisions that they had to make. We had another really quite terrifying case of a report of a child who was essentially abandoned by their parents with a life-limiting diagnosis because the parents knew that that was the best chance for the child to become looked after by the state and receive healthcare. Again, really heartbreaking. There were wider impacts of the hostile environments that were reported to us through lots of examples. These are just two of them, of clinicians dealing with many people with no recourse to public funds, so where migrants don't have access to any state support, so living in poor conditions, and many parents living in neglected, sort of squalid conditions, insufficient food, but parents begging for no referral to social services for fear of deportation. And that all of that had a massive effect on the community and healthcare staff. So healthcare staff felt that they, in one example, avoided the child and the family because they felt they had lack of clarity about entitlements and were afraid of having these conversations with families. So we found significant evidence of harm to families, to patients, and we found that the regulations were unworkable, and that overall clinicians thought the regulations were unfair. So what we did following this is we have written a guideline for pediatricians, so people working with children, with the Royal College of Pediatrics and Child Health, on how to advocate for migrant children who are chargeable. And the Royal College of Child Health is hosting a collection tool of cases where children or families might have come to harm, and continuing to do advocacy with the policy team. In terms of other things that we would like to continue doing, continue to just support for others, to continue to advocating for others to understand their role within these regulations and how to advocate for children, and continuing to organize against these regulations. Thank you for listening.
Thank you, Sarah, and thank you also, Jonathan. Your data brutally exposed the harm to pregnant women and children as a result of the NHS charging regulations. And your presentation was also compelling in its illustration of ethical dilemmas the healthcare professionals have to contend with. I'm just curious to know how UK compares to its European counterparts with regard to healthcare access for pregnant women and children. So could you speak on that, please?
Thanks. Yeah, so we're essentially worse than other European countries. We're not the only ones that charge pregnant women and children, but the kind of most comparable country to the UK would probably be France, in terms of its colonial history, economy, etc. In which France has a kind of active outreach program for pregnant women and children who are undocumented, which provides both free access to healthcare, but also goes further than that and tries to kind of do preventative work and extra kind of, they're entitled to extra care. Other countries such as Italy, Portugal, Spain are kind of very explicitly entitle children to healthcare regardless of whatever their kind of legal status is. And so I'd say that overall the UK stands out as being not the only one, but definitely on the worst end of spectrum in terms of access to healthcare for children and pregnant women.
Yeah, thank you. I think it also shows how we understand and how we construct and imagine vulnerabilities, and that at least gender plays also a role in our understanding of vulnerabilities and how we manage migrants. And I think that is also a good transition into our next topic, which is about the management of male asylum seekers in the UK during our current pandemic. So it is with really great pleasure that I introduce Seban Kenan. Let me just hang on. So Kenan is a Syrian asylum seeker who arrived in the UK last year. As a result of torture in a military prison in Syria, his mental health and physical health have severely suffered. His journey from Syria to the UK had also been traumatizing, not least because of witnessing death of other migrants on the sea. When he reached the UK, he was expecting a safe sanctuary. Instead, he found himself in Penally, an old army camp in Wales. He was the founder and the first chairman for the camp residents of Penally, and he's also the founder of a charity called Life Seekers Aid. And Dr. Seb Casalotti is a junior doctor. He has volunteered for medical legal organizations that are working to document the harm caused by barrack accommodation for asylum seekers in the UK. He's also part of Dogs Not Cops, a grassroots campaign who resists hostile environment policies in the NHS. Seb and Kenan, the floor is yours. Thank you.
Thanks very much. Can I just check that you're seeing the screen all right? Nice one. Well, thank you very much, Rogia, and thanks for giving us the opportunity to speak. So I'm going to go first. In the back end of last year, an ex-MOD training site was used in Penally, Wales to house over 200 asylum seekers. What I'm going to do is first talk about the results of data that we collected from conducting remote healthcare needs assessments of the residents there. And then I'm going to hand over to Kenan for his experience of navigating the current asylum system that we see. Just have to have a quick shout out that the views that I expressed here are my own and not of the organizations that we're affiliated with. So just a bit of a background of asylum accommodation in the UK. So there are different estimates for about 70,000 undecided claims for asylum in the UK at the moment. And a significant and rising number of these people are waiting over 6 months for a decision. Now, while people are waiting for these decisions, they're often housed in different types of accommodations. You can see one group that are with family or friends, often sofa surfing. The majority in contingency or dispersal accommodation, and group 3 who are sleeping rough or who are destitute at any given time. About 48,000 people housed in home office accommodation. Now, dispersal accommodation tends to consist of shared houses or flats in urban areas, but what we're going to be looking at today is contingency accommodation. So there are different ways in which this exists. And in this last year during the pandemic, we've seen an increase in the rise of uses of hotels and hostels, while they've not been used for tourism, to house asylum seekers who still have pending claims. We've also seen the increased use of temporary buildings or porter cabins outside detention centres like Yarl's Wood. And then also the use of barrack accommodation, so ex-army sites to house people who have often been fleeing war. The two that we'll be talking about mostly are Penally in South Wales and then Napier in Kent. It's important to distinguish this from the detention estate in the UK, which is comprised of immigration removal centres, where people are held with the intention of their involuntary removal to another country. So in theory, people in contingency accommodation are not barred from leaving the premises, and they're waiting for their asylum claims to be processed. It's intended to be a temporary measure, but the reality is that people have been in these places for months, and there's often no sense of the progress of their claim, and they exist in this damaging state of limbo. Importantly, there are certain rules that govern healthcare provision in detention centres which don't apply to sites like Penally and Napier, as they aren't detention centres. And a lot of the things that were coming out from the government was saying how people were screened for vulnerabilities and identified for vulnerabilities before they were moved to these MOD sites, like you can see on the quote on the right. So we decided to conduct these remote vulnerability assessments to really document whether there was evidence of vulnerability and assess the effect of the barrack accommodation on physical and mental health of the residents. It was quickly apparent that these screening processes were not sufficient, and of the people that we interviewed, many had been victims of torture, modern slavery, and trafficking. And the result of many of these interviews was that the evidence was successfully used to argue for the relocation of many of the interviewees out of the barracks, which many stated were redolent of the environments that they had experienced previously in their lives. Importantly, many of the interviewees also attributed their physical symptoms, in addition to their psychological symptoms, to their previous ill treatment. And the stats that are shown here show significant existing morbidity. There was a real consensus between interviewees in the feeling that there was a subjective unmet healthcare need amongst them. And this then translated into a really marked deterioration in their physical and mental health while they were kept in the barrack environment, with particularly the latter, mental health, needing considerable attention that wasn't received. So on top of the effect of being kept in dilapidated accommodation with no ways to occupy oneself, and people often being harassed by far-right groups at the gates of the camp, part of the reason for the deleterious effect on health can be explained by the very strange arrangements for accessing healthcare in contingency accommodation. So as Jess, Zara, and Jonathan explained earlier, asylum seekers are, as all people, entitled to free primary care and should be exempt from secondary healthcare charging. So should be able to access GPs themselves. And just for comparison, in detention, there's specific rules that require a trained GP to be on site and accessible by detainees. But Penally and Napier, there was a strange setup where residents often first had to go through a housing manager who would then book appointments for them and then arrange residents to be bused to a clinic where they wouldn't be able to get there themselves. Even despite the true valiant efforts of the local health board to provide services, they were given just about no notice of Penally being set up. So residents were often not able to reach appointments and did not want to because they had to go via a housing manager who was effectively acting as a surrogate GP receptionist while they were there. And because of that, that contributes to the unmet healthcare need and the people not being able to access those appointments. You probably won't be surprised to know that also there was a severe disregard for the health of asylum seekers in terms of COVID safety. So our data showed that there was supposed bubbling, but this was completely made ineffective by the fact that people had to congregate in communal areas to dine. There was overcrowding of all the shared spaces, and there was no testing at any point of people within the camp or before they were moved there, and no quarantining either. So the question that remains is, well, where are we now, having gone through this experience of these camps? Well, there remains a lack of both adequate interim accommodation and dispersed accommodation. And it's unclear how, with the reopening post-COVID and the lack of availability of these hotels, how there is going to be coping. Penally actually remains shut after an independent commission report, but Napier Barracks has reopened. Given that the conditions were actually objectively worse in Napier with a really bad COVID outbreak and a fire, it's unclear as to why Penally remains closed and Napier's reopened. And the fact that the government has claimed that the accommodation was reasonable and rational given the circumstances at the time leaves a lot to be worried. I think the previous presentations we've seen today showed that the existence of punitive legislation in the UK that forms the hostile environment can have negative effects on the health of migrants. And while the legal ramifications of the barracks are still under debate in court at the moment, what I think we see here is also the lack of a true corpus of public health law that was able to protect migrants from being subjected to the environments that we saw in the barracks. And within this current approach to asylum accommodation that's taken by the government, which is an approach that seems not to consider the physical and mental health of asylum seekers as part of its public health remit, it's possible to conceive how improvements could be made on some of the things I've spoken about, like COVID control and healthcare disconnection, which may lessen the detrimental effects of such contingency accommodation. But what can't be changed within this current paradigm is the effect of the disbelief, the contempt and hostility towards people seeking asylum, which I feel is encapsulated by the indefinite housing of people often fleeing war in barrack accommodation, and also the limbo that the current asylum system puts people in. So I'd like to pass over to Kenan at this point to really paint this picture for you.
Thank you, Sab. Thank you, everybody, for giving me the chance today and this opportunity to express myself. I'm a Syrian asylum seeker who arrived last year. So far, I have been in 5 different accommodations. One of them was Banali camp. Banali is a training camp in Wales, in Banali town. It's a remote area. I found myself there after being in 3 different accommodations. I was shocked by the condition inside the camp. You can see the photo right now. The sleeping quarter was shared to sleeping quarters. I had to share my bedroom with the other 5 asylum seekers in the time of the pandemics. The facilities was shared. We used to share the showers and toilets in the time of the pandemic with the lack of the hand sanitizers and the mask. Can you please go to the next slide? Yeah. In my experience of getting myself registering the GPs during the different accommodation, the first hotel was in London. I was unable to get myself registered with the GPs. There is no assistance at all. In noticing that I have just arrived to the country, I don't know the law, I don't know the process at all, but I didn't get any kind of help. In the second hotel, no GP registration achieved. The home office providers, the home office accommodation provider and migrant help provided the list of the GP, but I was unsuccessfully registered. In Banali camps, the situation was different. They tried to get us all registered when they move us to the camps, and the local GP was not prepared. So they tried to register more than 200 asylum seekers on the times. It took from them like 2 months to get us registered. Many of the asylum were in medication before. They were out of their medication. They are unable to get the medicines because simply they didn't get registered yet in the local GP, and the local GP was overloaded. Simply they were not notified that 200 asylum seekers will be moved suddenly to that town. Later on, I was being moved out of the camps through the schemes called Refugees at Home. With the help of my host family, I get myself registered with the GPs. I try to have an access to the or get an appointment with the specialist, mental specialist, during my bad experience with the torturing in my home country and being detained illegally in the military camps before in Syria. I was unable to get it. They told me approximately there is like a 30 weeks of waiting. Anyway, they put me on waiting, but later on I get dispersed accommodations in London again. So I had moved for the 5th time, but this time I get myself registered with the local GP again. But again, I didn't have the appointment yet with the mental specialist so far. Can you please go to the next slide? Yeah, during my period inside the camps in Banali, we established the CROP as associations from the asylum seekers. Initially we start interpreting for the other asylum seeker to get the medical help from the housing providers and others. Try to get them an appointment, try to pass their message to the housing provider, because simply the housing provider not having any interpreter or providing any interpreting service. Later on, CROP organized multiple online medicals and mental health assessment with doctor volunteers through Forest MLS Doctors, Helen Bamber Foundation, Doctor of Ward, and others, using the interpreter service provided freely from migrant help clear voice service. As a result, several assessments generated. And they get them treatment, and we successfully get some patients out of the camps through their solicitors threatening of the judicial review. As a result, I feel that the accommodations, the initial accommodation to be used for a very long term, especially during the pandemics, it's not suitable for the asylum seeker and the refugees who mostly are victim of torturing in their home countries. They have bad experience with the human trafficking during their journey, and simply they end up with such accommodation like the military camps. All that is affecting on their mental health and bring them very bad memories. and make it very difficult to them, even for the people who were able to speak English, to get the medical help or the legal help when it's needed. Thank you very much for this opportunity.
Kenan, Seb, thank you so much. That was a really powerful presentation. You gave us a lot to think about. You touched on, I mean, you also highlighted the distinction between legislation and implementation. So there are, you mentioned the lack of public health laws, but there were also there was also the lack of implementation of some existing public health laws. So you showed how the extremely poor living conditions of asylum seekers in the barracks and the way they are managed are not only detrimental to their health, but also breach the existing public health laws. You also painted very vividly the jail-like conditions in the barracks that result in health problems or compound the pre-existing ones. I mean, there's really a lot to talk about, and I do have some questions, but I'm kind of conscious of time and we are pushed for time. I was going to ask Kenan a question. I think, because I want also to give the audience a chance to pose their questions to us. So please do send us your questions in Q&A or the chat box. For now, I move on to our next speaker, and if there is time later, I will ask my questions. But thank you really very much. So public health is not only a concern of experts. Civil society is a central actor in public health. And that is what our next panelists will be speaking about. Alia will talk about the measures that are taken by civil society to resist immigration laws in the UK. So it's really an honor to have Alia with us. Alia Yule is an organizer at Migrants Organize, a platform for migrants and refugees to work together for dignity and justice. She works on the Patients Not Passports campaign, which is organizing with migrants, healthcare workers, and community groups to end hostile environment in the NHS. Over to you, Alia.
Thank you. Can everyone see my screen okay, the presentation? Good, great.
Yes.
Thanks so much for that introduction, Rogier, and for everyone else who's spoken so far. I've learned a lot, and it really, I hope to build on what's already been said. I want to talk a little bit about the response to the introduction of the hostile environment in healthcare and how different sectors across society are advocating for and organising around better healthcare for migrants, and also, better healthcare actually in the end for everybody. And I want to start by telling the story of Simba. Some of you may have heard this before, I know, but Simba's family came to the UK in 2004 from Zimbabwe. His dad came as a student, and Simba came, he was 14 years old. And in 2009, his dad had to apply for political asylum in the UK after his criticism of Mugabe's government led to a warrant being issued for his arrest in Zimbabwe. Simba was a child at the time. He later had to apply for asylum as on his own, essentially. But several times the Home Office refused their asylum applications. And as a refused asylum seeker, you are not allowed to work, you're not allowed to study, you are only entitled to a very limited amount of support from the government. And you were also not entitled to free NHS care. Simba had a blood clotting condition, for which he had been seeing a doctor, he had been seeing a GP, and the GP had told him he needed to see a specialist, but that it would cost him. And as a refused asylum seeker, he was unable to work. He was receiving £35 a week, I think, from the government. He couldn't afford essentially the care that he was being told that he needed. And so not only was he struggling against this kind of very basic denial of one of his fundamental rights of his access to healthcare and to live in dignity. In fact, earlier that year, back in 2018, 2019, His dad had also been put in immigration detention and threatened with deportation, which caused a huge stress to Simba and to his family. So not only was he unwell and unable to access NHS care, he was also under this huge amount of stress. And just before he was about to submit a new asylum claim, in June of 2019, at the age of just 30, Simba had a stroke, a result of the blood clotting condition. He was in a coma for 2 weeks. He had to have life-saving brain surgery to treat him. And one of the first things that happened when he woke up from that coma, that the doctors weren't sure if he was going to wake up from, was that the finance department of the hospital visited him in his hospital bed and presented him with a bill for £93,000. Simba likes to joke that it was a surprise that he didn't have another stroke when he saw the bill, which is funny, but also it's not, right? Prior to this, he had frequently been sent bills of thousands and thousands of pounds, £5,000, £1,000 another time, which he couldn't pay, and which is why he had stopped going for the treatment he needed. And, we can't know if he had had the care that he needed, if he wouldn't have had the stroke. But it is a possibility. And I want to tell this story because though Simba's bill is particularly high, his case is not isolated, and nor is what happened to him an accident. Over the last few years, as we, speakers before me have told, we've seen the growth of the hostile environment in the country. It is a concerted attempt by the government to demonize migrants and to push vast sections of our communities to the margins of society. So alongside charging in healthcare and sharing data, patient data with the Home Office, we've also seen the hostile environment be, in other sectors, with children's data from schools being shared with the Home Office, landlord being forced to check people's immigration status before renting them a house. The line has been blurred between immigration enforcement and the vital public services that people need to live. Yeah, there we go. It's not an exaggeration to say that the NHS, in fact, all of our public services are being turned into this new frontiers of border control. And since 2014, we've seen these significant expansions in charging that Jess spoke about, that Sarah and Jonathan spoke about, which essentially excludes hundreds of thousands of people living here who, for whatever reason, don't have the right documents, are undocumented or underdocumented. And there are many reasons that people don't have immigration status. And what we're seeing, as the speakers before me have really shown clearly, is that people are deterred from seeking the care that they need, are ultimately too fearful to come forward for care in case there are repercussions to their immigration status. That they might be denied treatment on the basis of the documents they do or don't have, questioned about their entitlement to care, about how they look or sound, and face huge delays in getting the care that they need. But one of the things that we do know, despite the inhumanity of what is happening, is that wherever there are these injustices in our society, charging and exclusion policies in healthcare there are people fighting back. Simba, for example, with his family, started the Justice for Simba campaign after what happened to him, along with the people of Sheffield. One of our organisers from Migrants Organised worked in the region and knew Simba's dad from his deportation campaign, anti-deportation campaign. And so together, alongside other organisations such as the South Yorkshire Migration Action and Asylum Group, These Walls Must Fall reps who campaign against immigration detention, and also alongside a group, Medac Sheffield, who are a group of healthcare workers and medical students in Sheffield, they formed a committee for essentially the Justice for Simba campaign, together shaping these demands to essentially call for all of Simba's debts to be written off, calling on Sheffield NHS Trust themselves to oppose charging for migrants, calling on the Home Office to grant Simba status, and also calling ultimately for the end to all NHS charging. The campaign created a petition which has now got over 60,000 signatures, I think, and have had several demonstrations outside the Home Office in Sheffield, including as part of a weekend of action against the broader hostile environment led by migrant community groups and organisations across the country last October. It included a poster campaign where people in all parts of the country put up that poster there of Justice for Simba, End the Hostile Environment, in hospitals, on boards in hospitals, on windows in their homes, or on public buildings. And it was this incredibly powerful display of solidarity with Simba and with all those whose lives have been destroyed by hostile environment immigration policies in healthcare. And it is ultimately this very powerful and very public outpouring of solidarity that will help us win changes against the charging policy. As a result of actually what's happened with the Simba's campaign and the kind of snowballing of it, the hospital has stopped harassing him to pay his bills. And he's actually receiving better care because they know that the people are kind of watching what's happening. Simba's campaign is actually part of a much broader campaign against the hostile environment in the NHS and for migrants to be able to access the healthcare that they need, which is called the Patients Not Passports campaign. It was Patients Not Passports was sort of set up by Docs Not Cops. Docs Not Cops, which many of the other panel members are members of, is a group that emerged in response to the introduction of the Immigration Act in 2014, which was what shooed in much of the hostile environment. And they held protests and took direct action, focusing on the expansion of charging and borders into the NHS, erecting fake border checkpoints outside hospitals in London to raise awareness of the harms of the policy amongst staff and the local communities. And then with the introduction of upfront charging and ID checks in 2017, the kind of latest iteration of the hostile environment, Docs Not Cops created the well-known, what is now known as the Patients Not Passports campaign. And we at Migrants Organised joined this campaign because of how we were seeing the policies impacting our members who are often too fearful to go forward for healthcare, who, as a result of the hostile environment, were frequently questioned about their immigration status, even where that shouldn't have happened by, as in what the policy states. And so we joined with this campaign alongside others, including MedAct and later the New Economics Foundation. Ultimately, what we're trying to work towards in this campaign is awareness about what the policies are and the impact of them, because one of the things that the hostile environment does across society is really push people to the margins and try and silence them by creating such fear that immigration enforcement might be around the corner if you speak out or if you try and oppose it. And so something that we have to do is really make clear what is going on. We want to have thousands of people opposing what's happening with migrant charging. We want to help people and support people to be able to advocate for those who are being denied or charged for their healthcare. Ultimately, we think that NHS trusts are going to play a really crucial part potentially in the overthrow of the policy, and by helping them to understand the impact that it's having on their patients, that they will come out and speak out against the policy. But that ultimately might require a policy of mass non-compliance from healthcare workers themselves to resist the policy, ultimately to win an end at NHS charging and truly universal healthcare for all. So the resistance is being led by frontline healthcare workers, communities and individuals targeted by the hostile environment, such as Simba, and local NHS campaigners, including groups like Keep Our NHS Public and others. And we, the groups are broadly working under this banner of Patients Not Passports, but there are groups right across the country working together to organise, to reach out to different organisations and people in their areas, to support people to access care that they need, to launch petitions, to hold stalls, to have public demonstrations, to have webinars and public meetings such as these, really to raise awareness about what's going on. And as part of the Patients Not Passports campaign, groups involved designed this toolkit, which is designed for different sections of society to be able to join in the campaign in the most effective way. So for healthcare workers, there are tools to be able to advocate for patients who are being charged for their care or being denied or refused care. There's also sections that allow community members to do this too. But also what the toolkit does is says, we can advocate on an individual level and support people who are, individually being denied or refused care. But ultimately, what needs to happen is for these policies that are causing so much harm to be overthrown. And that is only going to happen by us coming together to work in solidarity with each other to resist this. And I think it's really important here that we as a campaign, to underscore that we as a campaign, we are calling for the charging policies to be scrapped in their entireties. And so whilst that, there are exemptions for certain categories of migrants from charging policies, we don't recommend that there should be sort of further exemptions or revisions to the policies, because there is no version of the hostile environment that can be compatible with a truly universal NHS, nor compatible with a society that treats its members with dignity and respect. So if you have, increasing in numbers of exemptions to the charging policy or lifting of charges for certain marginalized groups, what happens is that you essentially concede that there are some people who do not have the right to health and who should be excluded from healthcare, either because that maybe they're not unwell enough, or they don't elicit enough public sympathy, or they haven't jumped through the right bureaucratic hoops with regard to their immigration status, or maybe that because they were born in the wrong place. This has to be a whole-scale opposition to the idea that there can be a health system which discriminates against people on the basis of their immigration status. There has been a huge amount of opposition that's growing from medical royal colleges, from trade unions, from the BMA, increasingly from MPs coming out to say that there is, the hostile environment is incompatible, particularly with public health during coronavirus. And I, of course, couldn't, do this presentation without talking about access to healthcare during coronavirus. Because the crisis has really laid bare the kind of structural inequalities and injustices that exist throughout society. And although, like TB and other communicable diseases, coronavirus is exempt from the charging regulations, what was abundantly clear to anybody who worked with migrant communities or who knew what the impact of the hostile environment was from the start of the pandemic was that if you have these policies in place, there are going to be groups of people who are either too fearful to come forward for healthcare, or because the hostile environment has kind of filtered through such that even when someone goes to register with a GP, even though it's not necessary, they will still sometimes be asked to prove their immigration status. And that will put that person off, coming forward for healthcare. And in the midst of the pandemic, that is going to result in those people not being able to access the testing, the treatment that they need, and ultimately also the vaccine. I will briefly tell another story of a man who's known as Elvis, who was undocumented. He lived and worked in the UK for over 10 years, along with his wife. And he had symptoms of coronavirus and became very unwell, but he was so fearful of the repercussions for his immigration status, or potentially for that of his wife, that he didn't come forward for the healthcare that he needed, despite urgings from other members of the Filipino community of which he was a part. And he unfortunately died alone at home, having not sought treatment, having not even called 111, because he was so fearful of immigration policies in the NHS. And this is something that we're seeing across lots of different communities, that has been a result of the pandemic. So I think, what that kind of knowledge really led to groups understanding that in order for the vaccination program to work, what needed to happen was that the whole of the hostile environment had to be scrapped, that there needed to be a firewall introduced between the Home Office and the NHS to allow people to come forward without fear, which has happened in other countries, in Portugal, in South Korea, in a number of different places, Ireland. The USA even said that ICE wouldn't be present at any vaccination site. And so, different organizations, including royal colleges, charities, 8 different local councils, and many others signed this call saying that, ultimately the hostile environment has to end in order that people are going to be able to get the vaccines. That happened alongside lots of really interesting work happening kind of behind the scenes to ensure that people could get the vaccine, with pop-up clinics in Hackney, and actually in lots of different places, vaccine buses driving around, being able to vaccinate everybody, not asking questions about immigration status. Some places saying that no data, when people went to get vaccinated, no data would get shared with the Home Office, and they did this by having paper records rather than entering things onto digital databases and so on. And so what we saw really with all these initiatives was this clear recognition of the problem of the hostile environment and how it interacts and causes problems for public health initiatives. And what we saw was this amazing response from civil society with local authorities, CCGs, communities trying to overcome this. But it's a sticking plaster, because ultimately, whilst immigration controls still exist in the NHS, there will be people who are unable to come forward to get the healthcare that they need. And so to win, ultimately, we're going to require mobilizations across every sector of society, united in our opposition to any attempts to undermine the universality of the NHS and to scapegoat migrants. And this is what the Patients Not Passports campaign is working towards. And this is what we're calling on everybody to be a part of. Thank you very much for listening. And I'll post some links that I hope will be helpful in the chat.
Thank you, Alia, very much. Thank you for adding this important layer to our discussion. You also offered us some ideas and ways forward, and I can see how human rights to health framework can be a unique way to galvanize democratic participation and hold states accountable and draw attention to marginalized groups. It's only because, hang on, let me see how much time we have left, because we only have, only 15 minutes left. So I was gonna ask you a few questions, but I genuinely want to give our audience a chance to ask, to put their questions to you. So instead of me asking questions, I'm actually gonna see what questions we have in our Q&A. So Rebecca is asking, patients with no NHS number get flagged to the overseas offices automatically on arrival to secondary services. Are there any campaigns that exist about resisting this automation of enforcing anti-migration policies within the NHS? Who wants to take this question, please?
I can make a brief comment about the fact that that absolutely reflects what we hear from healthcare workers, unfortunately, across multiple different settings, that a lack of NHS number is used as a means of identifying people who may be chargeable for care. There are other digital mechanisms that are used to flag people up. The Patients Not Passports campaign that Ali has talked about is a broad-based campaign that's national, and I would encourage you to find a local group and to join it, because we need to absolutely try and challenge this kind of practice.
Yeah, thank you very much. Sarah?
I was just going to add that we also, as for those of you who are clinicians, we have a responsibility to not shy away from sort of these policies that we don't like, and actually go and speak to those patients who are being deterred or asked about all of these questions, and really speak to them and find out if there's any potential exemptions, any ways you could advocate for that individual case. And the other thing I would advocate is, if you see any cases that come to harm from delayed care, then these things are, they need to be reported. So either use the Royal College of Paediatrics reporting tool, but also that needs to be a DATEX for those of you who work in hospital, because it's a patient who came to harm. So the more we all get involved with this, as much as we don't like it, and really work with those patients to document the harms and try and advocate for those individual patients, hopefully the more that, will become apparent that it's really unworkable.
Okay, thank you. Seb?
The only thing I wanted to add to this was also to show how part of the problem of these systems is that once the infrastructure is in place to have these charging mechanisms, it becomes harder to move away from them, and it's easier for them to extend into other routes. I think this touches on one of the next questions, talking about the impact of the cost of healthcare charging. And one of the things that is often talked about.
Sorry that I interrupt, but would you mind when I just read out the question?
Yeah, go for it.
Because so the question is, what would you say are the best ways to counteract the argument that the charging is necessary to combat medical tourism? I know that this makes up a tiny proportion of people using NHS services, but I have heard this argument used a lot when I advocate for all charging immigration status checks to be abolished. Do you have any good stats arguments against this? So sorry, Seb, carry on.
And on this idea, we often talk about there's very little evidence or no evidence at the moment that the charging regulations are economically sound. However, as we've seen, with a lot of the cost is through the implementation of them and having the infrastructure to put them in place. And it is conceivable that with more of this infrastructure in place, things could become more economically sound. And that's why I think it's not good to take that approach. And we really need to be highlighting the healthcare rights approach that sees healthcare as a right and not a privilege, rather than going into these ideas of whether it is economically viable or not to charge migrants.
Jonathan?
Yeah, I completely agree. Thanks, Seb. I mean, you can't play into the, we should be trying to create an alternative narrative, which is around healthcare rights and the harm caused by charging. I mean, if you do want some stats, the cost of implementation is undeniably much more than the cost of these measures. People that want to come and have kind of high access healthcare will pay for their healthcare. You know, in pediatrics, we've got lots of patients who want to get UK standard healthcare, and they will just pay. That happens. Independently of that, undocumented migrants account for about 0.03% of the NHS budget. And sort of on a hospital level, just to give you a sense of that, a hospital I worked in recently, when I had those statistics, the costs that were recuperated from charging these groups was, I can't remember exactly, forgive me, but it was in the region of, you know, sort of £60,000, £70,000. The cost of staffing that office was over £100,000. And just to give you context, the overspend of printing, that's not the printing budget, that's the overspend. The amount they went over was £5 million. So the money is just completely different. And, you know, implementing charging systems is more costly for the NHS overall. So we need to create alternative narratives. This is about healthcare harm. This is about healthcare rights, but also from an economics perspective, it makes no sense. It's all about immigration discourse.
Thank you very much. Hang on, there is another question. I tried to challenge my GP's office for saying they needed proof of address and ID to register a new patient, but they didn't seem to care that this was not actually the law. So it is again about implementation. Is there any mechanism for us to hold them accountable?
I can jump in briefly on that. I'll put it in the chat, but there is a really good leaflet produced by the NHS, which clearly lays out entitlement. I mean, there's lots of places that talk about entitlement. So Doctors of the World do a lot of work around GP access and entitlement, and everyone is entitled to access to GP. So that's the first point. The second point, this is a leaflet I often print out for patients. It tells them how to find a GP, but also it asks the GP surgery to tick a box to say, I've rejected this patient, which they're not allowed to do. And so it's just a way of forcing the practice to face up to the fact that they're doing something that's against the regulations. So I find that quite useful. Doctors of the World are a good place to go if you really struggle, because they will advocate on many people's behalf in terms of helping them support getting access to.
Thank you very much. And then there is another question that is for you, Seb. A question for Seb about the activities he undertook in Penally camp. Was there any coordination with the local NHS organization like a health board, GP practices? Were you given access to the initial medical screening results from the Home Office about the individuals you were assessing?
It's a really good question, thanks. So what we have to say was that there were considerable efforts taken by so many different, both local groups, local volunteer groups, and the local health board to try and provide a system to achieve the health needs of the people within the camp. The reality was that this site was opened with just about no notice given to any of the local structures, and suddenly 200 people with significant healthcare need moved to an area with really poor healthcare access anyway. And so even though there was an attempt at coordination here, it was often not achievable at the time frame that was needed. In addition to this, the local GP practice, where people should ostensibly have been registered, was just not able to cope with that level of demand after that. And so that is one of the real problems of having these designated sites that are propped up very, very quickly, as opposed to dispersed accommodation in urban environments, when there isn't a real emphasis placed on the healthcare of the people kept within them. And this is almost, this healthcare disconnection seems an inevitability.
Thank you very much. we have few minutes left, so there may be time for one of the questions I was going to put to the panel. And so I'm kind of curious to know what impact do speakers feel that the Black Lives Matter movement could have on the campaign to defend migrants' right to health care? Alia?
Said we're gonna, no, I can go.
Yeah.
Yeah, definitely. I mean, I think it's a really important question, and I think the BLM movement of last summer and sort of continuing this year has really highlighted that, like, what structural racism actually is and how it exists. You know, I think the pandemic was beginning to expose that, the number of the deaths, you know, the disproportionate number of deaths that we were seeing from migrant and BME communities, and BME communities coming out and saying this isn't about some kind of, you know, inherently we're more unhealthy or whatever. This is about actually this, you know, social determinants of health, of which racism, and particularly structural racism, is a really big part. You know, we saw this when so Simba's campaign was raised by his MP Olivia Blake in Parliament as part of Black History Month, because she was saying, you know, one of the things that we see is as a result of structural racism in society is these worse health outcomes, and that is part of, you know, the racism that we witness. And I think NHS trusts are more willing to hear that and understand that and recognize how, when you, for example, embed policies which require people to essentially discriminate on the basis of either what you look like, your foreign sounding name, potentially what you sound like, whether or not you've got an NHS number or not, you know, all of these things end up, you know, embedding discrimination into the heart of the NHS. And that, you know, this is what I'm saying by when I say that we see the hostile environment sort of filtering through into, for example, GP practices. So about the question where they just insist that actually, you know, they do need to see someone's, you know, immigration status. That's, again, it's not because the law says so, it's because they have been told by the rest of society that this is something that we should be doing. We now need to start be asking people on the basis of potentially what they look like, what they sound like, you know, so on, whether or not that they, you know, are entitled, question whether or not they are entitled to services, as opposed to understanding that everybody should have the right, you know, everyone has the right to health, everybody has the right to live a dignified, healthy life. And, you know, and so it has exposed, I think, essentially what structural racism is and what that looks like institutionally inside the NHS is a really opening.
Thank you very much, everyone. That brings us to the end of our webinar. There was really so much in what we discussed today. 2 points that I mean, there's a lot to take away. So, but 2 points that I will remember are that firstly, migrants are, I mean, migration is a social determinant of health. And while most migrants are healthy, if they cannot access other determinants of health, like healthcare and appropriate housing, this may rapidly result in poorer health. Secondly, healthcare systems do not appear from a void, but rather they are shaped by cultural norms, morals, and politics. The aspirations of today become the laws of tomorrow. Ultimately, the question we need to ask ourselves is, what fundamental values do we seek to foster and promote within our societies? Thank you so much to everyone for staying with us right to the end. It has been an honor. Thank you again to our incredible speakers for their time and expertise. And the recording will be online soon. Have a wonderful afternoon, everyone, or whatever, evening, morning, day. Bye-bye. Bye-bye, everyone.